My name is Dumbrill, and I've been tasked with giving you the two talks on the gynae scanning. All right, so the learning objective, so the first talk is basically going to be on normal findings, and the second talk will be on abnormal findings that you might see. So, sorry. Click on. Let's try this now. I'm just trying to move it. Right. Okay, so my hope is at the end of this lecture that you'll be able to recognize the typical ultrasound findings of a normal gynecological ultrasound examination. And the key questions that we want to answer is, what is the correct scanning technique to image the cervix, the uterus, and the ovaries effectively? And what are the principal ultrasound features of the normal cervix, the normal uterus, the normal ovaries and adnexae? And finally, how do you recognize a correctly positioned IUCD? Okay, so let's start with the transabdominal scan. So there is international consensus that when we scan abdominally, that we always have the image aligned in a certain way. So it is accepted now that the patient's right-hand side should be on the left-hand side of the image, and the patient's left should be on the right-hand side of your screen. And there's also international consensus that when you scan sagittally or longitudinally on the uterus, the same applies, in that you have the patient's head on the left-hand side of your screen as you view it, and the patient's feet on the right. And this is quite important because it means if you see an image in a journal, you'll automatically be able to orientate yourself, and it makes the interpretation a lot easier. In terms of gynae ultrasound images, well, there's agreement only on the transverse view. And like in the abdominal view, they like the patient's right to be reflected on the left side of your screen, and the patient's left on the right-hand side of your screen. However, there's no real consensus as regards to the longitudinal scan, where the footprint can even be reflected on the top or can be reflected on the bottom. And indeed, there's also different positions where you can put the bladder. So you can put on the bladder on the left or the right, or the left or the right, depending on whether you're scanning with the footprint up or down. So to start, if you're going to scan a patient with a scanner, you can either scan abdominally or you can scan vaginally. So with the abdominal scan, you've got the probe on the abdomen, and the structures that you're looking at are quite far down to the pelvis, namely the uterus and the ovaries. So therefore, if you know anything about the physics of ultrasound, you need to ensure that you have a low frequency, which gives you a poor resolution. However, it does give you a good overview. So often you can see uterus, the entire uterus, sometimes even both ovaries. And also you can ensure that if you've got a large ovary which might extend into the upper abdomen, that you will be able to see this quite easily. And if you feel the inclination to go and look for kidneys or the liver, then you can do this at the same time. Generally, it's accepted that for transabdominal scanning, you have a full bladder, and the reason why you have this is that you can actually displace the gas-filled bowel out of where you want to see. In terms of vaginal scanning, you're obviously a lot closer to the areas of interest, so therefore you need a higher frequency. You have superb resolution. However, you're limited by the structures that you see, in that you're going to only see a uterus and often one ovary perhaps in a view, but otherwise it'll be single ovaries. You're unable to see in the upper abdomen, so if you're scanning a woman with an enlarged ovarian cyst, you might not see it at all. And generally, it's the accepted principle that you have an empty bladder. For the reverse of the abdominal, and that if you have a full bladder, it might take the structures that you're trying to view outside the field of view. So the most important thing when you do a gynecological ultrasound is your scanning technique. And you heard this morning, or earlier on this morning, when you scan the fetus, that you should take the six-step approach. And it's no different when you scan the uterus, that you should be scanning in a specific order. And I was always taught that you look at the pathology last, and the reason why is if you get all excited about the ovarian cyst that you're seeing, you often forget to look for the other ovary and the measurements of the uterus. So that when it comes to writing your report, you find that you haven't got all the information you need. Right, so how do I perform a vaginal scan? Essentially, you insert the scan into the vagina, and as you slowly insert it, you should see your urethra and your bladder. on the one side, and on the other side, you should see your rectum. As you go to the top of the vagina, you'll see the cervix that comes into view with the posterior vaginal wall behind it. And then you start seeing the internal and external os of the cervix with the canal. It's very important that you follow this canal upwards, because that's the only way you can ensure that the endometrium that you think you're looking at is actually the endometrium. It's also common to see Nabathian follicles in the cervix, and that's of no worry. So once again, you're now following up the internal canal up, and following it into the endometrium, and the more you push, the more of the fundus of the uterus you'll see. So you start recognizing the uterus as you see it there with a clear endometrium. By dropping your hand, you can normally see the fundus of the uterus. So, and this is the important plane that you need if you're going to take an endometrial measurement, because you want the endometrium to be parallel to your scan. In addition, this is the correct way to measure the ET if you're worrying about postmenopausal bleeding. Ideally, it's not, you can't replicate it in the transverse view, and the reason why you might be scanning obliquely and then you'll have an increased measurement for the ET. And certainly, if you're also going to measure anterior and posterior myometrium, then this is how you do it. Then, what you normally do when I finish doing the longitudinal slide, if you got your probe, you actually want to scan to the left and you want to scan to the right. And the reason why, that's how you're going to pick up if there's other pathology within the myometrium in terms of fibroids, adenomyosis. Once you finish scanning this way, you then turn your probe 90 degrees, and then you look at the transverse view of the uterus. And once again, it's important that you scan from the bottom or the top up, depending on which way you do it. So you should start with the cervix, and you scan up through the uterus. And that's important because if you pick up a septum or something, the only way you're going to see it is on that transverse view. And your measurement of the uterus is at the top of the fundus. Okay, so there are many ways that one can go about finding an ovary. And it's a matter of trying all of them and seeing which one best fits you. So if you're doing a transverse scan up to the uterus, more often than not, you're actually going to, as you're scanning up, you're actually going to see one or both ovaries shortly out of the midline. And that's very easy to retrieve them when you go back to look for the ovaries. The other way of finding them is this way. You go to your fundus, okay, and you follow the tubes down, and it's normally an S-shaped curve to the pelvic sidewall until you find your ovary. Then the best thing once you've done is once you find one ovary, I split the screen so you keep that image of the ovary. You then turn your probe 90 degrees, and then you freeze it on that image, so then you're going to have your both images of the ovary, and you can measure them that way. Likewise, you should also be scanning up and down through your ovary and left and right, because you might pick up adnexal pathology that way as well. And your aim here is to measure the maximal width of the ovary. And then when it comes to finding the ovary, the second ovary, you basically repeat that technique that you've done. A technique that I sometimes use, if you've got your one ovary in view, in a certain position, if you pull your probe out, go across the cervix and straight into the exact same level, most of the time you'll find the other ovary straight away, and an anatomically normal pelvis. If there's been surgery, then that ovary might be somewhere else. So other techniques that are used for finding ovaries is you can obviously go straight laterally like you do with an abdominal scan. You put on your color flow and you look for your internal vessels, and depending on which way you scan, the ovary will be either above or below the vessel. And finally, the other little trick that I've got, if you can't find an ovary, go and look behind the uterus, because on your sagittal view, sometimes right at the top, there's a ovary that's stuck, and it's obviously, it's a small ovary which is normally up there, and that's where you'll find your ovary. So this is just showing you the technique to go down the other side. Okay, fluid in the pouch of Douglas is normal, especially at the time of ovulation, and if you're going to measure it, that's how you measure it there. Sometimes fluid in the pelvis it's easier to see other structures. So this is the fimbrial end, which you can often see. It's not normal to see tubes or the fimbria, but if there's fluid, you sometimes can see it. And finally, when you, on exiting the female pelvis, it's now suggested that you look at the bladder, especially now with evidence coming about of deep infiltrating endometriosis. You can often see bladder nodules and polyps within the bladder. And they're actually very easy to see because normally by the end of your scan, your bladder started filling with urine anyway. Okay, so ultrasound is a dynamic and it's an interactive examination. I've put the slide in today. It basically shows the importance with how interactive ultrasound is. So what you're doing here is you're using your probe to determine the mobility of that ovary. So by sliding the probe between the uterus and the ovary, you can actually separate it off and see whether it's mobile. And then by going laterally, you can see if it's stuck to the side wall, and often if it's stuck to the uterosacral ligament. And this is actually quite a nice trick, because if you're seeing, sorry, let's go back again. If you're seeing a mobile ovary like this, okay, and you can quite happily probe it, it's very unlikely that whatever pain she's getting will be coming from this ovary if you can do this test. So in terms of soft markers that they speak of, a site-specific tenderness, if the ovaries are fixed in any way, and then free fluid. So the other dynamic investigation you could do is looking at the pouch of Douglas, and this is to assess whether there's pouch of Douglas of obliteration or partial obliteration. So essentially you put your probe in the posterior fornix, and by pushing you'll see quite easily that there's movement of the cervix. So it's kind of like doing a cervical excitation tenderness but with your probe. At the same time you can see that there's movement of the bowel off the back of the uterus and at the top of the uterus. And in this way you can actually ascertain that there are no adhesions behind the uterus, which once again is a technique that will be used for assessing for deep infiltrating endometriosis. Okay, then onto abdominal scan. I mentioned before, you ideally like a full bladder for your abdominal scan because it will help displace the bowel from where you want to see. But it very much depends on if you're using this your abdominal scan to complement your vaginal scan. So if you've done a vaginal scan first, it's not essential that you have a full bladder for the abdominal scan. Once again, you should have a systematic technique because in that way you will not forget anything. So if you scan with the sagittal view, remember from that first slide, we want the fundus to the left of the screen. Once again, you should follow the cervix, the vagina, down, see the cervix, follow the cervical canal up to the fundus, because that's the only way you can ensure that you're seeing the endometrium. Transverse section, much the same way. You follow it from the bottom, from the cervix to the top, to the fundus. In terms of finding ovaries, there are two techniques. So the one is that if you're scanning longitudinally, it is accepted that you just you go off the midline by 45 degrees, try and get your pelvic organs, your pelvic vessels into view, and often you're going to find your ovary there. And another way of doing it would be if you're now scanning transversely, you also go 45 degrees, and often you'll find your ovary. It's more difficult to find ovaries transabdominally than it is transvaginally. And that's how to find the ovaries. Okay, in terms of normal ultrasound appearance, obviously there's a different appearance of an ultrasound in a premenopausal as opposed to a postmenopausal woman. And often because menstrual cycle is under hormonal control, there will be differing appearances of the uterus and ovaries during the cycle. So in terms of what we should look for, so this is obviously a sagittal view of a section. What you want to see is a smooth contour at the top of the uterus. You want to see a generally homogeneous myometrium, and you want to make sure that the anterior and the posterior parts of the myometrium are of equal size. So in terms of the endometrium, these are 4 pictures of the same woman as she goes through the cycle. So the picture on your left that you see, that's the appearance of a very thin endometrium post menses. As you proceed through the proliferative phase, you have a thickening of the endometrium, and that you see this triple layer approach that you see. At the time of ovulation, there's normally a little spurt of progesterone, and that leads to a thickening of that endometrium, the proliferative phase. And in the secretory phase, you get a loss of that triple layer appearance, and you get the hypoechoic solitary endometrium that you're seeing there. In terms of changes in the menstrual cycle, this slide is taken through with the same woman through the same cycle, and it reflects not only changes in the endometrium but also changes that you're going to see in the ovary. So the top left corner, it's that very thin, discernible, barely discernible endometrium that you see post a period. And if you look at the ovaries, you see an ovary that's often quite difficult to see, but you have the beginnings of follicle development with 3 little follicles. Just shortly in the proliferative phase, 3 days before ovulation, the top picture, you can see that the tri-layer approach of the endometrium. And in terms of the ovary, you have a dominant follicle that is now present. And you normally have regression of the 2 smaller follicles. At the time of that dominant follicle, normally at this stage is about 1 centimeter, 10 millimeters. And if you do follicular tracking, you'll notice that grows at about a rate of 1 to 2 millimeters per day. So the third picture you see is the one around the time of ovulation, and obviously the dominant follicles is a lot bigger. And then finally, in your last picture on the right, you see just your monolayer endometrium, and the ovary that's there is the corpus luteum. So the cyst wall is a lot thicker. If you've got color Doppler, you can put color on, and you'll see the typical ring of fire, although corpus luteum will have different appearances, so it might trick you. But that's what it looks like when you put on the color. So, yeah, as mentioned, the corpus luteum has different appearances. You might have a solid corpus luteum, you might have a cystic corpus luteum. Sometimes you might be bleeding into that corpus luteum, and you have like a hemorrhagic corpus luteum with like a spider web appearance. So just be aware of all the different appearances. Okay, as I said, it's normal to have fluid in the pouch of Douglas, especially in premenopausal women. It is an unusual finding in postmenopausal women, so if you see it, you should probably investigate further. And if you're going to measure it, that's how you measure it. All right, so how big is a normal ovary in women of a fertile age? Okay, so the studies show that the average size of an ovary is very variable. This is a study that's quoted, 303 women aged between 20 and 39 years old. These women having regular periods. And the median size was 7 mils with a range of 2 to 17 millimeters. And likewise, what's the normal number of antral follicles? Once again, there's a huge variation. If you look at the textbooks, they say 67 follicles per ovary. In this study, they had a median of 11 with anything from 2 to 10 follicles with a range of 1 to 36. So the 10th centile in the study showed anything from 4 to 20 millimeters. Now, if you know the diagnosis, the Rotterdam diagnosis of polycystic ovaries, they say you need 12 follicles to diagnose PCO. So if you look at this study, then up to 50% of the patients would have been diagnosed with polycystic ovaries. And these are women with normal periods. So what is apparent is with our ultrasound getting better and better and our resolution, we're seeing a lot more follicles than we used to see previously. So there's now a suggestion that they're going to redo the Rotterdam criteria, and you're looking at 25 follicles before you can diagnose polycystic ovaries. Okay, so the correct position of an IUCD, well, there's 2 types of IUCDs you're likely to see. The one is the copper, and that's a lot easier to see because obviously that stem becomes very echogenic. So what you basically want to see is that white line, which is situated in the fundus, as shown there, and then transverse view, you can actually follow the stem of the copper up to the top where you should be able to see the T. Mirana's or the progesterone-containing IUCD is a bit more difficult. So what you look for there is you look for the fallout. You can often just see the tip, which is a bright white light on either side. Is this? It's not actually showing there. And then in transverse, once again, you can follow the stem all the way up to the top, and once again, you get that fallout of the arms. So there's another example of a correctly positioned IUCD. Okay, so sometimes there's a fad at the moment, especially at Grooterskie and Mowbray, where they're putting in devices at the time of cesarean section, and obviously then you've got a big uterus. And then we get to see them 2 or 3 months later where the uterus is involuted. And it's amazing the different shapes that can happen and the different positions that you can see with these IUCDs. These ones are quite easy to see if they're just low in the cavity, because you can follow up the IUCD, then obviously you can follow the rest of the fundus. And you can see that that's too low in the cavity. In terms of 3D, I have a 3D on a 3D probe. The uses I use this for is women can actually recognize the Mirena before I put it in, and then when you give them a 3D image like this, then they can see that it's in the right place. But I always diagnose my incorrect positioning not on 3D, I diagnose it on 2D. And it's just by following the guidelines that I've shown you. So these are some examples of an incorrect position IUCD. And once again, it is nice if you've got 3D to get confirmation of it. But when I scan a Grooterskie, we don't have 3D, so we just have to make do with our 2D, and it actually is good enough. Okay, right. So in terms of normal ultrasound findings in postmenopausal women, well, there's obviously atrophy. So the uterus of a postmenopausal woman tends to be smaller than the premenopausal. It still has its smooth contour. What you're likely to see, though, is you often see calcification in the vessels within the myometrium, and those are depicted there. In terms of finding the endometrium, the other thing that happens with postmenopausal uteri is they tend to go upright, so more axial, so they lose their either anteversion or retroversion. And you'll appreciate when you scan that you actually need to have the uterus flat when you're scanning to get an accurate measurement of the ET. So in terms of what we should be looking for, the 9th and 10th centiles, anything from 2 to 5 millimeters. Okay, and don't worry if you see an endometrium that's more than 5 millimeters, because as long as they're not symptomatic with bleeding, then the risk of malignancy and everything else is very low, and I wouldn't actually inform them. And likewise, finding a postmenopausal ovary can sometimes be very difficult because they don't have follicles anymore. So they tend to be quite dark, and they often you'll struggle to see them within the bowel. Occasionally, you might see an inclusion cyst, and that's as long as it's less than 10 millimeters, it's not a problem, and that's reflected in that ovary on the right. And once again, how big is a normal ovary in postmenopausal women? So this study took 144 asymptomatic postmenopausal women between the ages of 45 and 65, and they found a median age to be 1 to 2 centimeters. It's actually quite small. I normally take anything up to 4 mils as normal. The importance with this is not to do about the size of the ovary. You'll see in my subsequent talk, it's got to do with the look on the ovary. So the same with premenopausal ovaries. We should be looking grayscale pattern recognition to delineate abnormal from normal, and not be based or guided by the size alone. Okay, so the basis for gynecological ultrasound, you need to orientate yourself in your image. And whatever way you've been taught to scan, you should probably continue with it, because that's the way you used to. Always use a systematic scanning technique, and just practice the same way, because in that way you'll become familiar with it and you won't miss things. I scan upside down because that's the way I was taught when I was in the UK. And the reason why I do that is because if I scan abdominally and I scan vaginally, then the image of the uterus is the same. So if all of you want to learn how to scan, making it a lot easier for your brain to understand, then I flip the image like this. And that's how I choose to scan. Thank you very much. Any questions?
So if the IUCD is in the wrong place, either too low, or do you then take it out and put it back in, or put a new one in, and if they're pregnant because of the abnormal position of the IUCD, do you take it out or do you leave it in?
So it depends on, so I normally try and push it back. So if it's a Mirena and they've spent 2,500 rand for it, to get it, I often try and push it back in. with a probe. And no Grudiski, they try the same thing. The Mirenas do have a policy where they will replace your first Mirena for free if somehow it's moved or you've put it in the incorrect position. And in terms of pregnancy, my understanding was if you can see the strings, then you grab it and you remove it. But if you can't see the strings, then you just leave it in the uterus. I don't know where the next one is.
Just a comment on downwardly displaced Mirenas. They shouldn't be removed. In fact, when the Mirena was first developed by Lukainen in Finland, they actually made an intracervical device, which they never marketed, because they realized a lot of people wouldn't put them in properly. And on many trials, it worked perfectly. They work perfectly right, even if they sit in the cervix.
You know, the Grudiski teaching for the copper IUCDs, if it's more than 2 centimeters, they do remove and replace. Yeah.
May I ask you something? I don't do personally gynecological scans, but every time I do a vaginal scan, well, I have always to flip the image because you showed the way you use it, and usually in the obstetric vaginal scan we do it the other way around. We showed it also this morning. So I think it's very important that you always use the same approach, because then you can compare images. Mm. Is that what you would recommend?
Yeah.
Yes.
Yeah, definitely. I mean, it's the way you're taught in the hospital. The King's approach is to flip the image. Everybody has a flipped image. And so that's what I got used to. Mm. And when I got back here, everybody had the image the other way around, but I couldn't change.
Yes, I know. At King's, you also learn to scan with your left hand. And then when you go back home, you have to change it all over again.
All right, let's find the next one.
Okay, so then you minimize this one.
Yeah, let's pass to the next one.
In a woman who's had an endometrial ablation, subsequent scanning, what is normal and what's abnormal? Sometimes see women in their perimenopausal ages previously had an ablation, and now you see fluid levels within the uterus, and you see what looks like active endometrium. What should you accept in the perimenopausal woman as normal and abnormal in the ones that had ablations?
Okay, so the appearance of an endometrial ablation endometrium often is like an Asherman syndrome. So you'll see interruptions of the endometrium. So that'll be a normal finding. In terms of if you're seeing fluid in the cavity in a postmenopausal woman, it's completely normal. And it's actually nice to see, because then you can actually see the endometrium either side. It's like a natural saline infusion sonography. So what is recommended then, if you have fluid, that you mustn't measure the entire ET, that you've got to actually take the endometrium on either side of the fluid and add it together, and that's your ET measurement. But other than that, you've got to treat it like a normal endometrium in terms of the measurement. So, you know, if she's asymptomatic with bleeding and she's above 4 or 5 millimeters, then you do need to sample.